Hi, everybody, it's Professor Miller. This lecture is going to focus on alterations in immunity and inflammation. So, when we go through some of these concepts, they may seem very detailed, but really it kind of gives you that foundation for a lot of disease states that we'll kind of discuss throughout the course. Like a lot of the hypersensitivity reactions are related to things like allergies or um, autoimmune disorders like rheumatoid arthritis or diabetes. So really, a lot of this pertains to, underlying disease states and really kind of putting it together with a big picture, essentially. So I'll try to point that out as we kind of move through. In terms of hypersensitivity, I'm sure you're well aware of, hypersensitivity reactions or allergic reactions. And, it's when you mount that immune response to an antigen, essentially. However, there are times where we start to have, dysregulation here, and we have, the self is recognized as an antigen. But in general, what happens is it will result in disease or damage to the host. So really, there's different types of hypersensitivity reactions. When we talk about general allergies, obviously that's a hypersensitivity to an environmental or exogenous antigen. And obviously, or have seen allergies, in clinical practice. When we look at hypersensitivity reactions as well, there is the link with autoimmunity. So when we go through the different types, I'll try to point this out in terms of which ones cause what. But really with autoimmunity, it's a disturbance there in the immune function essentially and intolerance against self-antigens. So, you develop tolerance when we refer to it, and this means essentially is that you lose that ability to only target, exogenous antigens or antigens that shouldn't be there. So what happens is they lose that, the tolerance there, and they start to target self-antigens or your normal healthy cells, essentially. So autoimmune diseases, the immune system reacts against self-antigens to such a degree that the person's own tissues are damaged, essentially, by these autoantibodies or, autoreactive T cells. So there's two different hypersensitivity reactions that cause disease. One, is more related to like an antigen antibody complex, and the other is more related to like your T cells and destruction there. When we talk about alloimmunity, essentially that's where you have an immune reaction to tissues of another individual. A great example of this is, like a transplant rejection. So essentially, you're mounting a reaction against your, someone else or the non-self cells, essentially. There are different hypersensitivity reactions, and we're going to take a look at all of these. Obviously, it's characterized by the mechanism underneath that underlies it. There's type 1, which is IgE-mediated. And these are the common, hypersensitivity reactions that you most commonly think of in terms of like an allergen. Type 2 is tissue-specific reactions. Type 3 is immune complex mediated. And type 4 is cell-mediated. And we'll take a look at each one of these. I added this chart. I just felt like it was a great way to look at it. It gives you a brief, concise view of each one. Once again, type 1 is more of those allergic responses or anaphylaxis. It's IgE-mediated. So remember when we talked about antibodies, they have those, IgE, IgM, IgG. Well, this is usually mediated by IgE. So remember that's always related to like allergies. Where type 2 is cytotoxic. And we'll go through these, in more detail. But basically this is more related to like autoimmune diseases like Graves' disease, so thyroid. So you basically have cytotoxic antibodies that attack healthy tissues. So, thyroid disease, myasthenia gravis, and I'll give you examples as we move through. Type 1 diabetes is a perfect example of this. So you develop, cytotoxic antibodies to those pancreatic beta cells, and that's why they lose the ability, to produce insulin, essentially. So type 1, as we brought up before, is an autoimmune disorder. Transplant rejection is another example. Type 3 is immune complex reaction, essentially. So with this one, they have an antigen-antibody complex that basically deposit within tissues. A great example of this one is rheumatoid arthritis and systemic lupus. And we'll talk about lupus, as we move through. Rheumatoid arthritis we'll cover too, like when we get into musculoskeletal, but that is one great example of immune complex or type 3 hypersensitivity reactions. So with this, they, get, destruction of the tissue there because they actually deposit within those areas. Vasculitis is another example of this. Now, type 4 is a delayed hypersensitivity. And really what happens with this is it's more of a slower response or a delayed response, obviously, and it's cell-mediated. So usually you'll see this a lot with like a topical contact dermatitis, like you would see it with like poison ivy, which we'll go through as we move through. Or even the TB skin testing, that's how it's done. It's through that delayed hypersensitivity when you have a result there. But we'll take a look at these as we move through. When we look at hypersensitivity too, we kind of divide them out into, severity and then the onset, obviously. So obviously immediate means that it occurs within minutes to hours. Anaphylaxis, I'm sure you're all well aware of that or have unfortunately potentially seen this in practice, but this is when it occurs, pretty immediate to exposure to that antigen. And usually you'll have that massive systemic response to that antigen. And this is where you have all those inflammatory mediators and, potent modulators like histamine that cause that, urticaria, or they have hives, or they have, you have that massive shift in fluid or edema, and then you get, swelling of the throat and all that. So obviously it's a very severe reaction. Delayed hypersensitivity reactions may take a little bit longer. So a lot of times it's, hours later, or even possibly days later after that antigen exposure. And we'll talk about these kind of as we move through. Going back to type 1 hypersensitivity, so this is that IgE-mediated, so remember allergen. The big, potent mediator here is mast cells, or basically the chemical mediators that are released by mast cells is what potentially produces the symptoms here. It's against allergens, obviously, or antigens. The big thing, too, to understand is that it takes repetitive exposure, essentially, to that antigen in order to have that significant response. So, and I actually have it on another slide, and I'll show you, but, the first time you're exposed to an allergen, let's say it's just peanuts, you're not going to end up with a hypersensitivity reaction at that point because it takes, the body to develop antibodies against it and become sensitized, essentially. And that's what mounts the second response. So the second time the patient is exposed to it is when they'll have the allergic reaction. And essentially it could get worse, obviously, as it goes on. IgE binds to the Fc receptors on the mast cell. So it's basically binding to the mast cell. And then you have degranulation of those mast cells. And remember when we looked back at mast cell degranulation and synthesis of mediators, that's all things like histamine, leukotrienes, prostaglandins. So really what it's doing is triggering that significant acute inflammatory process. So, if you go back to look at the immune response, it'll kind of make sense. And histamine is one of those major mediators that are involved with a type 1 hypersensitivity, like an IgE-mediated one. And we kind of talked a little bit briefly about where histamine receptors are, so H1 and H2. And that's why we use antihistamines too for allergic reactions, because it stops or it potentially tries to help, stop the process of histamine release essentially for that. So H1 receptors are found in, the bronchial smooth muscle. So that's why you'll see airway hypersensitivity or you'll see airway constriction. H2 receptors, remember, are located in your gastric parietal cells, and that'll increase gastric acid release. So really, like when we think of, an IgE-mediated response with like bronchospasm, where they have chest tightness, wheezing, things like that, that's all because of histamine in those receptors that are located in the bronchial area. So with IgE-mediated hypersensitivities, obviously we do give antihistamines, but and you probably already know this, but with a acute anaphylaxis, you're always going to be giving epinephrine or EpiPen. At that point, an antihistamine might help a little bit with their symptoms, but it's not going to halt the process of it. So that's an important fact to kind of realize. This, again, I just added these images because it kind of gives you a picture with, what occurs here with, exposure to allergen on the upper right. And that first, exposure to allergen basically initiates that class switching of B cells. And that's basically, remember when you think about class switching, that's where you develop a specific antibody against that antigen. So you get more production of the IgE, B cells essentially. And, that's where it attaches onto mast cells. Well, what happens, once again, when you have a repeat exposure, you're already primed. So you're basically, your system's, already primed and sensitized. So that's when they develop a reaction essentially to that second bout. Once again, the immediate hypersensitivity usually related to like things like histamines or cytokines, like I mentioned before with leukotrienes and prostaglandins. In this image is the same kind of thing. This is a mast cell with IgE and basically degranulation and releasing histamine and all those other mediators. And then, like you'll have those later phase responses with like prostaglandins and leukotrienes. So essentially, it's just kind of the same thing that I was just talking about. This image I just added to, and it was basically about, sensitization. So basically, it takes, exposure to that allergen, allergen or antigen essentially to develop, those antibodies. So it's the second bout that they have exposure to that they develop an allergic reaction to. So you can go out and take a look at that. It's essentially just basically what I went through. Obviously, with type 1 hypersensitivity reactions, you can have a multitude of symptoms. The big ones that you think of is itching and urticaria, so hive-like reaction in patients, essentially. And I have an image on the next slide. You can have redness of the eyes. So you even think about, allergies, just general allergies and, overall. You have that redness or itchiness of the eyes, itchiness of the throat, rhinitis, which is basically like a runny nose. On the more severe level, when you think about, histamine release and increased capillary permeability, you have that massive fluid shift. So if you have, severe infection, they have this huge, significant shift in fluid from intravascular to extravascular. So that's why, too, you can develop hypotension in those severe cases. So their blood pressure will be really low. And it's not uncommon, too, to see tachycardia because when your blood pressure drops, your heart compensates and increases the heart rate in order to maintain cardiac output. Bronchospasm, like I already mentioned, you have, constriction of those the bronchial airways. So it's not uncommon for them to have difficulty breathing, shortness of breath, wheezing, etc. Dysrhythmias too, and it's kind of related to all those other factors too with like hypotension and receptors that are located elsewhere as well. Patients can have GI symptoms as well. It can, you can have increased acid from the H2 receptors, but you can also have a shift in fluid into the GI tract, and you can have diarrhea. They can have cramps, so that's not an uncommon factor as well. They don't have to present with all of these, obviously, but can be a multitude of symptoms in the patient. So these are examples that I already kind of went through. Angioedema is essentially swelling of the face, and you might have seen this as well, especially if you work in the ER, you might see this because patients will present with this. A lot of times you'll see it by the mouth, like you'll see significant swelling by the lips, or you'll see it by the eyes, or just general overall facial swelling. You can have angioedema in other areas too, in the groin area, even in the hands. So you just get significant swelling or fluid shift there. When you think of just general allergies, conjunctivitis, rhinitis, because with conjunctivitis, you can have allergic conjunctivitis, or you can have bacterial, or you can have viral. So there's 3 different types of conjunctivitis, but allergic conjunctivitis is usually like the itchy red eyes. They don't tend to have a lot of drainage with it. They'll just be red and, they might be watery with it. But essentially, these can be related to type 1 IgE-mediated reactions. These are just other examples that I added. I thought it was just a good way to look at it, because even minor things, like you think about insect bites, it's IgE-mediated. So all of these factors, like even just when we talk about general hay fever, allergic rhinitis, it's mediated by IgE. Bronchial asthma, when we get to asthma, asthma, like I mentioned, is an inflammatory disorder that's heavily mediated by allergies. So allergies and asthma, and in fact eczema too, they all go hand in hand. You can have food allergies. So these are just different, allergens that you may see in terms of an IgE-mediated response. And essentially you can look at like the symptoms that you might see with it as well. But once again, on the right, it talks about mast cell degranulation, and basically you have all these inflammatory mediators that are released, and that's why they end up with the symptoms that they do. Obviously, anaphylaxis, the severity depends on the level of sensitization. So as I mentioned before, it's those future exposures that they're more at risk for, or more at risk with, because of basically they produce more antibodies against it at each. It's kind of just like we talked about with antibody production in general. The more that they're exposed to it, they can have a more severe reaction. In terms of when we look at, skin testing, there can be, they can have a reaction to a little amount. Or if they're getting allergy shots, you have to be very careful with that because we always look out for anaphylaxis or, symptoms of an allergic reaction after. So a lot of times they can get, all these symptoms that we already talked about in terms of, that systemic response there. Laryngeal obstruction, obviously airway obstruction is the big one that we always watch out for. There is a genetic predisposition there, so allergies in general, even things like asthma and all that, they tend to run in families. In terms of diagnostic testing, usually, obviously, you're going to be sending them to an allergist, for diagnostic testing. You can do it in primary care in terms of doing a panel through blood work. And you can test like laboratory levels of IgE, doing it for specific allergens, essentially, through blood work. However, a lot of times at this point, usually you'll send them to an allergist too, because they can do skin testing. And obviously, if, they have significant allergies, a lot of times patients will opt to do, injections essentially, and which is desensitization. So basically when they get minute quantities of the allergen, through injection, and they basically increase the dose very slowly, basically to sensitize that patient to the allergens. And obviously, once again, you're always watching out for an allergic reaction with that. But basically, the allergen becomes neutralized and it's unable to bind with those mast cells or with IgE on mast cells, essentially. So it is very effective. But once again, at this point, you would be referring to an allergist. Where type 2 hypersensitivity is a little bit different. This basically is a tissue-specific antigen. It's the target of an immune response. There's different mechanisms. So cells can be destroyed by antibodies, such as IgG, IgM, or the complement cascade. So all these inflammatory mediators or portions of your immune response cause cellular damage or cell destruction. So these antigens also can enter circulation and deposit on tissues. Once again, it starts that whole complement cascade and produces damage at the cellular level. Obviously it can cause that cell to malfunction in general. A good example of this would be like myasthenia gravis, and I already mentioned things like diabetes. We talked about a couple of different ones at the very beginning. But when we talk about like induced cell malfunction, this is basically a motor end plate with myasthenia gravis. And what we're looking at is that junction between like that neuromuscular junction and acetylcholine receptors, essentially. Well, what happens is that in this case, there's basically an antibody that develops towards those acetylcholine receptors, which are these right here. And these are obviously the receptors. Well, what happens is that these antibodies essentially go into the receptor area and block the typical acetylcholine that needs to, essentially target those receptors and activate basically muscular contraction with it. So what happens, obviously, if it's blocked by these antibodies, it decreases the effectiveness, or it won't let acetylcholine work there, essentially. So that's why they end up with like muscle weakness and all that. So once again, this is like an antibody complex that causes cellular dysfunction, essentially. So this is basically an immune complex mediated. So there's immune complexes that travel, go to certain areas, and cause dysfunction there. It's formed in circulation, and then it's later can be deposited in certain areas, like certain tissues or even the vessel walls. So it's not potentially organ specific. So a lot of times with these states, it'll basically go to multiple areas, essentially. And, there's different size immune complexes, whether it's small or large or intermediate. The small ones tend to be renally cleared. The large ones actually tend to be taken care of by macrophages essentially, but the intermediate ones are the ones that actually can deposit and cause pathologic consequences essentially. But obviously, once again, you have all these chemotactic factors, and it basically mounts that immune response and can cause tissue damage, obviously. This is just an example. I mean, it looks pretty complicated when you look at this image, and really the big thing is look at the, where it says number 1, immediate size complexes deposited in the tissue. So once again, then you have that complement system that's activated. And then you end up with like the chemotaxis where you get neutrophils and, all those inflammatory mediators that essentially go there. And then neutrophil adherence and degranulation. So obviously this is what, causes tissue damage in the certain areas as well. Some good examples of type 3 of complex mediated disease is lupus. Lupus is a big one. Vasculitis is another one. So you can even have these immune complexes that deposit on that vessel wall. And once again, it initiates that complement cascade and the inflammatory response, so they end up with vasculitis. Post-streptococcal glomerulonephritis is another great example. So with strep pharyngitis, which is basically what this is related to, with just general strep throat, there's certain strains of strep that are more prominent to causing this, or more prevalent in, causing post-streptococcal glomerulonephritis, essentially. So what happens is they develop these immune complexes, and they actually deposit within the kidney, and they can cause renal damage. And once again, it's the same thing. It potentiates that complement and inflammatory cascade, and basically they can end up with renal damage from it. And this is really, really why it's so important to make sure that we, strep throat essentially gets diagnosed promptly and the proper antibiotic treatment is given for it. And another thing, too, is making sure that the patient's finishing their course of antibiotic therapy, and being compliant with it. Because this is like a later stage result of, unfortunately, of, after a strep throat infection that's not treated, essentially. But there's certain strains that have been linked with a higher prevalence, essentially, of this. Another good example is actually reactive arthritis. And this you can see after like you might see it with like an infection. A good example is actually gonorrhea. I've actually seen it with patients that have basically have had a gonorrheal infection and they didn't know that they had it. This patient was a male, and all of a sudden presented with acute swelling of the knee. So what happens is that they develop complexes or immune complexes, that circulate throughout the body, and sometimes they'll kind of aggregate to one area and present with something like that. So like I had a patient that just presented with a knee effusion, and it almost presented like a septic joint essentially. But this basically can be like a reactive arthritis to an infection essentially. So these are just some examples of when you might potentially see like a type 3 complex, immune complex mediated disease. Where type 4 hypersensitivity is a little bit different. This is mainly mediated by T lymphocytes. So this is not where you have like an antigen-antibody complex. But what happens is they get tissue destruction directly by those T cells, essentially. And basically, a lot of times, too, once again, you have the cytokines that recruit phagocytes and macrophages. They all kind of go to that area and cause tissue damage. Examples of this, one that you commonly will see in primary care is contact dermatitis or contact allergic reactions. And I'll show you in a few slides some examples. But it's another factor that contributes to Hashimoto's, which is actually thyroid dysfunction. And we'll talk about that as we move into endocrine as well. But this contributes to the destruction of the thyroid. And, basically can lead to hypothyroidism in the patient. Another thing too is, like I mentioned at the beginning, like your TB testing. This is basically how it's, how it's triggered when you have a reaction there. This is complicated as well. My main reason for putting this on there is essentially to just basically show you that it's mediated by your T helper cells and not necessarily a antibody-antigen complex. And what happens is that you can have, apoptosis of your cells, so cellular death or destruction essentially there. A great example that you commonly will see in primary care, you'll see a lot of contact dermatitis in primary care, a lot of derm in general in primary care. So this is an example of poison ivy. So with poison ivy, there's oils basically on the plant. And when you have, exposure with your skin proteins, or if you have contact with it, there's catechol molecules, which is from the plant. So it basically combines with skin proteins, and it can develop a response there. Once again, though, kind of like an allergic reaction, you basically take that initial response or initial interaction with your immune system, and you develop T memory cells. So right at that beginning or primary contact, they aren't going to have a reaction essentially with it. It's that secondary contact that they develop dermatitis with it. So those T memory cells basically can remember this, and they basically mount that inflammatory response against your tissue, and then you end up with the rash essentially from it. So it's that secondary contact that you'll get it with it, but it's T cell mediated essentially with this. But with dermatitis, you'll see it a lot, and this could be other factors too. Like if you had jewelry or something like that, or even like latex is another thing too. So these are examples of like more of a contact dermatitis. When we look at an allergy, you pretty much probably already understand this, but antigens that cause an atypical response, and it's a lot of times, like I said before, it's genetically predisposed individuals, so it tends to run in families. Remember, type 1 is more things like pollens, molds, fungus, foods, animals, etc. So it's more of those environmental factors. Where type 4 is more of those contacts. So you'll see type 4 with contact dermatitis. It's very common. Poison ivy, metals, like I mentioned with jewelry, you'll see it with that. Chemicals, like certain soaps, just exposure to things that the patients utilize, or cosmetics, things like that. And I always ask that, like if you see a rash in a certain area, you can tell by the pattern as well of where it presents. If it's on the hands, like what did they change recently? What have they been exposed to? You always want to inquire about those factors because it usually will help you, figure out the cause. So basically, there's an original insult there once again, and they're both kind of the same factor. Like you have that original insult, and then you have a secondary, immune response against it. When we look at autoimmunity in general, and we'll talk about these as we move through the course, but there's a breakdown in tolerance, like I mentioned at the beginning. So basically, it's breaking down the fact that we're now recognizing cells as foreign. So basically, self becomes an antigen. And there's different terms here, like sequestered antigen. And actually, I don't expect you to remember every single little thing here. I'm just trying to give you an example of how these kind of present, or why they present, essentially. Sequestered antigens is actually kind of interesting. They're normally not actually seen by the immune system. It's kind of a hidden state. And sympathetic uveitis is actually a good example of it. With this, there's a previous trauma or surgery to one eye, and actually kind of goes through the sympathetic nervous system, but they actually will present with, redness or eye pain or swelling in the opposite eye. So it kind of transmits, and it'll present in the unexpected eye, essentially. And it can happen, further down the road, even like a year or two later. So it's kind of a sequestered antigen. So, there are odd things that pop up like this. Infectious disease is the thought process behind it, with molecular mimicry. So these antigens of infectious agents closely resemble a particular self-antigen. So they're, the thought process here is that, it's so close that you start to recognize self as an antigen, essentially, because of that. Neoantigens are another area. Essentially, neoantigens are like a newly developed antigen that's never been recognized by the immune system. It can be from potentially viral proteins that they may see it, or it's been linked even with drug reactions. Like an example would be like a hemolytic anemia. And once you get into pharm, like you may talk about this as well, but there's certain drugs that have the predisposition to cause, or a side effect that we worry about, or adverse event of hemolytic anemia. But basically, it's kind of confusing, but your body starts to recognize it as an antigen. And they react with it, or the antibodies react with it, and then it can, in the case of hemolytic anemia, it actually can lyse that red blood cell. So these are just examples, essentially. Another example is a forbidden clone. So basically during differentiation, lymphocytes produce receptors that react with self-antigens. Another example is ineffective peripheral tolerance. So there's just defects there in your regulatory cells. Original insult, another example would be, like I mentioned before, with strep throat. There is a M protein on that bacterial capsule that basically induces antibodies that also react with proteins in the heart. So I'm sure you've heard of things like rheumatic heart or rheumatic fever, and valvular damage. We talk about, that after a strep infection. And the thought is it's linked to like these M proteins that are on that bacteria. And they have, basically it reacts also with the proteins on that heart valve. So essentially they can, end up with damage to that valve in the heart. And this is essentially kind of how it occurs. There's also genetic factors too with HLA alleles to present that antigen. So once again, this kind of links it back to a genetic factor as well. One example that we'll discuss, in this lecture is systemic lupus erythematosus. So once again, it's an autoimmune disease and it's multi-system. So that's important to remember too. So it's not, a lot of times they present with joint pain at the very beginning, but it's not just their joints that it can affect. It can affect their kidneys, their heart, their lungs. There's a lot of different factors that you have to really think about. But they can develop antibodies against nucleic acid, erythrocytes, coagulation proteins, phospholipids, etc. But what happens, they can have deposition of circulating immune complexes containing the antibody against the host DNA. It has a high affinity for the glomerular basement membrane, essentially. So that's why they end up with a lot of kidney, dysfunction, essentially, from it. So we're very careful or cautious with monitoring their kidney functions as well. It's definitely more common in women versus men. Some of the clinical manifestations, once again, a lot of times they present with joint pain. So, they'll present with arthritis or morning stiffness that lasts a long time. A lot of times it's symmetrical arthritis. They'll present with both sides, like both hands, both feet. But that's probably the number one reason for them seeking out care. Another thing that you'll see too is like Raynaud's phenomena, where they have, like when they're exposed to cold, they'll get constriction of those arteries on the fingers, and they'll have, where it looks kind of white in comparison to the rest of their tissue. Vasculitis can occur with it. Rash. Rash is very common, where they get that butterfly rash on the cheeks, essentially. But renal disease, once again, is very common as well. You will see patients with hematologic changes as well, or cardiovascular disease. I did add these. These were just some general symptoms that you'll commonly see, like I kind of mentioned. But I thought it was good because it kind of puts it together with in terms of treatment. And like I mentioned before, you obviously don't have to know about treatments at this point in time. And you'll learn more of this as you move through pharmacology as well. But, once again, it just shows you the prevalence of having, joint pain, fatigue. Those are other things that are common. Neuropsychiatric symptoms can occur with it, or pulmonary symptoms can occur with it as well. In terms of diagnostic criteria, I try to add this in a little bit as we kind of move through different disease states. But once again, at this point, a lot of times these patients are referred to rheumatology, for a further workup. The reason that I added this is a lot of the times what we'll do is look at an ANA blood work sample on the patient. So a lot of times an ANA is done on a lot of patients that present with autoimmune type, with an autoimmune presentation, essentially, if they have those signs and symptoms there. However, an ANA is not a specific test. A lot of times, ANAs will be positive for other reasons. And it doesn't necessarily point you to the direction of one autoimmune disease versus another. Because you may have an ANA that's positive for, rheumatoid arthritis versus lupus. However, it's a red flag. And it's kind of one of those screening tools that we use to basically prompt us to look into it further and, draw further blood work on the patient. But once again, we'll look at different things, like do they have a skin rash? Do they have any hematologic changes? Do they have, lymphopenia or leukopenia in the patient? Looking at any pulmonary symptoms. The malar rash on the face is a big one, too, that you commonly see. And a lot of times it's exacerbated, by sunlight and things like that. But these are just some, things that you can take a look at. And I just added it because I wanted to mention about the ANA as well. There's 11 common findings that you'll typically see. You may have serial or simultaneous presence of at least 4 that can indicate lupus. Once again, sometimes these patients too will have bouts where they'll have a flare up of one area, not necessarily the other. They may not have a rash at that point in time, but they may have more joint pain. But I added the table on the right, once again with the ANA as well, because I just wanted to make, the point that it's not necessarily just, indicated for diagnosing lupus, but it's also used for other rheumatic diseases, like scleroderma, rheumatoid arthritis, drug-induced lupus, different types of autoimmune disorders. It could even be elevated in things like Graves' disease or Hashimoto's thyroiditis. But if they're positive, it shows that there's potentially an autoimmune process going on. When we look at the term of alloimmunity, once again, I brought it up at the beginning, the immune system reacts with antigens on the tissue of another genetically dissimilar member of the same species. So essentially, like I mentioned, this would be like a transplant rejection. It can happen in the neonatal period. It can happen with transfusion reactions. So it's basically just mounting that immune response against, somebody that's non-self, essentially. In terms of immunodeficiencies, when we look at this, we look at it whether it's a primary or a secondary immunodeficiency. So primary means that it's either a congenital deficiency or more of a genetic immunodeficiency that is there. Where secondary is obviously acquired, and there's multiple reasons for that as well. But there can be an impairment in T cell function, B cell function, phagocytes, or your complement system. So there could be one little area that you have an impairment essentially with like your primary immunodeficiency. The biggest symptom of this, or the biggest prompt to looking into this, is usually those patients that present with many infections. Like they'll present with a lot more infections than you would expect in a patient. And they also present with opportunistic infections or organisms. So those organisms that the normal healthy individual typically wouldn't have an infection or present with. So it's kind of those rare infections that they'll present with. The type of infection actually can help you lead to the diagnosis of the type of deficiency. So there's certain infections that are linked with certain deficient areas. So like a gonorrhea or disseminated gonorrhea can usually be linked with a complement deficiency. So remember when we talked about like your immune response, remember all those little areas of your, the complement system, you can have a deficiency, essentially in any one of those areas. An onset of acute viral infections where they have a multitude of viruses can suggest a T cell deficiency. So these are just things that can kind of lead you to understanding that, or linking it with it. You can have, and I don't expect you to memorize all of these. I just added it on there for examples. So like B cell deficiencies, like you may have a patient that has recurrent bacterial infections. For instance, I had a patient that had recurrent sinusitis, and it was a chronic sinusitis. Like the treatment with any general antibiotic would not get rid of it. She actually had to go to infectious disease, and it was discovered that she had an immune deficiency. So it's kind of cases like that, that they're very difficult to treat, or the antibiotics are unsuccessful, or like I said, they present with very atypical infections. So like your T cell deficiency, sometimes you will see with like a viral or fungal infection or protozoal infections, complement deficiencies, phagocytic deficiencies. But once again, the big thing, like I said, is that they get these reoccurrent, very severe infections. So once again, I already mentioned that they have severe infections, and the T cell deficiencies tend to go with like a viral or repetitive viral infections, fungal infections, yeast infections, or any atypical microorganism. Whereas B cell tend to occur with microorganisms that require opsonization. So basically, with opsonization, they basically kind of flag the microorganism for phagocytosis with it. Complement deficiencies, sometimes you'll see with meningitis or systemic gonorrhea. So those are things that you will see with that, and it's like more of a severe, obviously, infection with that. Primary, like I already mentioned, is a congenital or genetic anomaly. Secondary is usually caused by another illness, which is definitely more common than a primary. So really, when you think about this, You want to think of other secondary causes of immunity or immunodeficiency, because like I mentioned, this is far more common than those primary deficiencies. So things like malnutrition, HIV is a big one that we worry about. Malignancy, any immunosuppressive agents. So if the patient's on medications like high-dose steroids, or they're on like Enbrel, things like that we use for autoimmune disorders, a lot of those agents essentially suppress the immune system, in order to fight autoimmune disease. However, it suppresses the immune system, so then they end up, with a secondary deficiency there. Protein loss, I already mentioned that. Metabolic disease, things just such as diabetes, severe liver disease, uremia. Obviously, a splenectomy is going to put them at risk as well. So really, when you're thinking about it, you want to look at your patient's meds as well and think, is there anything that can contribute to, chronic infections essentially as well? These are examples of ones that I kind of went through. Normal physiologic conditions, things like stress that we kind of talked about before, dietary insufficiencies, malignancies, the big one. So anytime there's an underlying malignancy there, they're at significant risk as well. And obviously, too, the chemotherapeutic agents are going to put them at risk. And a lot of the medications that are used for treatment. Trauma, medical treatments. The medical treatments is unfortunately a very common cause, so you really have to think about that. Other infections that can occur, if they have like a long-standing viral syndrome like AIDS, obviously they have a secondary deficiency. Environmental factors and metabolic diseases like diabetes and so forth. When we evaluate immunity, and I'm sure you all have looked at CBCs before, and we look at a CBC with differential. So really, when you see your patients now, like in the clinic setting or in the hospital setting, start to look at that and analyze it. Look at your CBC, look at your white counts, and look at the differential, and see if you can kind of point things out like that, like if they have elevated neutrophils or eosinophils, and try to, look at the clinical presentation of your patient and see if that pattern kind of fits with it. So really start taking a look at like your CBCs and your lab results to kind of put that together. Obviously, so once again, we look at the CBC. And like I mentioned before, when we talked about the general immune response, remember your neutrophils are basically that acute reactant that you'll get that elevates usually with a significant inflammatory response or inflammation or infection. So in your patients, look at stuff like that and see what their neutrophil levels are. Basophils are very common with allergies. So sometimes you may have a patient, that has allergic rhinitis that's very severe at one point in time, and their basophils might be elevated. Eosinophils, allergic conditions, once again, you'll see eosinophils rise with that. So start to look at that and see if it basically coordinates with that as well. So obviously white counts in general are going to be elevated with infections. There are times where you have viral states that can cause a drop in white counts too, like in general, looking at your white count. But we'll talk about that kind of as we move through different, disease states or particular infections essentially, further in the course. You can you can draw blood work on immunoglobulins, like sometimes we'll draw an IgE, IgG, because they can be deficient in, certain immunoglobulins, obviously. And once again, when we go back to looking at, like infectious disease, a lot of times we'll utilize that for diagnostic testing as well. You can look at complement deficiencies. Usually at this point, if you're suspicious of, like of a primary immune dysfunction, you're going to be referring out to like an allergist and an immunologist essentially for a further workup on the patient. Obviously with allergy testing, that's another thing that can be done as well. Treatment for immunodeficiencies, and you'll get into this when you get into pharmacology, but there can be gamma globulin therapy, and I know I mentioned it before, like IgE, so IgE replacement essentially. And what it is they're basically antibodies that are basically prepared from a large number of donors from the plasma essentially. So what we're doing is giving them a replacement of IgE. So you're giving them that immunoglobulin, but it's temporary. It's not, it's not long-lived essentially. So it's a short-term intervention essentially. There can be transplantation of, a stem cell transplant. That's more of a long-term or longer-term intervention essentially. Soluble immune mediators and gene therapy are also alternative options as well. But once again, as I mentioned, like if you're patient has an immune deficiency like this, they're going to be seeing, an immunologist, or if it's an infection, and infectious disease as well. So if you have any questions on this, please let me know. And then the second lecture after this will cover infections in more detail. Thanks.